Hey everybody, welcome back. Here we go. Little hiatus there. I missed you guys. What can I tell you? It was about a week off. Although Mr. Tanzola did give us a good video on medical mission planning, which was very informative. For my non-FBI folk, sorry, we kind of kept that one internal. Let's see, what's been going on over the last week? All kinds of craziness. Hopefully you're safe and well wherever you are. It's been a little nutty this week. Obviously, I was pulled away for a couple of things, but I'm back. I think we're going to try and do one video a week from this point on. I'm trying to do 2 videos. The op tempo is getting a little, we're starting to come out of COVID, so it's getting a little busier. So I don't know if I'm necessarily going to have time to do 2 videos a week, but I'll definitely try and get 1 video a week out at a bare minimum. Shout out to Atlanta. I was down in Atlanta last year. Had a good time down in Atlanta. Always having a lot of fun. Let's see. What's new and exciting, guys? Haven't seen you in a week. One of the biggest questions I've been getting, believe it or not, is how in the world am I doing this? Because I've asked guys, hey, people give me recommendations and ideas, and I appreciate and I want those. I welcome those ideas. But then sometimes I turn right back around. If I'm not the subject matter expert on something, I'll turn to them and say, hey, can you make the video for me? And they email me back or call me soon after and say, that was a pain in the ass. I don't know how you do it. So I'm just going to give you a little glimpse here as to how I prepare for these videos beforehand.
Ribs. I had ribs for lunch. That's why I'm doing this.
How now, brown cow? How now, brown cow? How now, brown cow? Unique New York. Unique New York. I love scotch. I love scotch. Scotchy, scotch, scotch. Here it goes down into my belly. The arsonist has oddly shaped feet. The Human Torch was denied a bank loan. Ho 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 ho.
On in 5, 4.
When the clock struck 6, it meant one thing for Ron Burgundy and his news team.
I love it. Love it. Only thing that would make that better, that video better, a little clip better, if he's drinking Jack Daniels, not scotch. Okay, let's see. Nothing classified, nothing sensitive. We're going to talk about head injury today. We'll start pulling a little bit away from medical. We'll get a little bit into trauma. The only trauma topics we really covered thus far, only topic, has been burns. Chris has been putting out some good videos on, for my FBI folk, on TCCC and TCCC reviews. So let's talk a little bit about head injury and how they present. Head injuries can be very difficult to assess, especially if your patient's drunk. Go figure. That ends up being some of the trickier parts of assessment for a head injury patient is if they're already intoxicated, if they already have altered mental status, if they're already under the influence of something, and you're trying to assess them for a head injury, that tends to be difficult. But what we'll go over is different types of head injury, how they might present, how we assess them, and how we treat them. And really, quite frankly, treatments for us are minimal. We'll talk about some of the advanced things, but primarily we'll keep it pretty basic. So let's talk about head injury and start off with just your regular, everyday cranium.
No! Well, let's have a look at the replay. William, move your head. Look at the size of that boy's head. Shh. I'm not kidding, it's like an orange on a toothpick.
Shh, you gotta give the boy a complex.
Well, that's a huge noggin. It's a virtual planetoid. Shh. Has its own weather system. Heed, move! Heed, paper, now! Move that melon of yours and get the paper if you can. Hauling that gargantuan cranium about. I'm not kidding, that boy's head's like Sputnik. Spherical, but quite pointy in parts. Well, that was offside, wasn't it? He'll be crying himself to sleep tonight on his huge pillow.
All right. Can't go wrong with that. So let's go ahead and put this slide up, and let's do a little bit of anatomy and physiology right out of the gate. So I remember when I was first going through school and learning about anatomy and physiology, I was always under the assumption that the skull was one big solid piece. I couldn't have been more wrong if I tried. The skull is made up of a number of separate bones that come together at those suture lines. And the brain itself, the terminology of the brain itself and the skull, or the areas of the skull, are one and the same. So your frontal lobe corresponds with the frontal area of your skull, parietal, temporal, occipital, so on and so forth. But the skull is made up of many different types, or not types, but different bones all fused together. In past videos of anatomy and physiology, we discussed a little bit of the fontanelles, the anterior and posterior fontanelle on your children, or your 18 months old or younger, and that's where those fusion points, so those suture lines that you see in this picture here, haven't quite come together yet. And that allows the baby's head to condense down through the birth canal and expand back out. So when we talk about head injuries, we're going to look at not only skull fractures, but more at the brain tissue level. We're going to look at concussions. We'll look at traumatic brain injury, DAIs, diffuse axonal injuries, different types of bleeds, that sort of thing. And we'll see how they might present, and unfortunately, how little there is that we can do about it, or what little there is that we can do about it. So different types of fractures, depending on what book you read, you'll see all kinds of, you can have a linear fracture, you can have an open vault fracture, a depressed fracture, a basilar skull fracture. Okay, great. How am I going to know if somebody has a linear skull fracture? Okay, a linear skull fracture is just a crack in the skull. I really don't care, quite frankly. I'm not going to splint it. There's nothing I'm going to do about it. What I am worried about is that energy wave that caused that fracture. Is it going to now transfer that energy into the brain tissue itself? So if I have a cardiac contusion, I've bruised my heart. If I have a pulmonary contusion, I've bruised my lung. If I have a cerebral contusion, I've bruised my brain. Bad thing about cerebral contusions, and we'll get more into this later, is there's nowhere for it to go as far as swelling. All right? If I bruise my heart, I bruise my lung, although that can be deadly. Is there room for that tissue to swell? Sure. Again, if I get punched in the mouth, my lip is going to swell, and there's nothing in the way for that swelling to occur. If I bruise my brain, there's really nowhere for it to go. Right? So I'm not so concerned necessarily about the fracture itself of the skull. I'm worried about what's going on underneath. So in this picture here, this is just showing the base of the skull as far as anatomy and physiology review go. Because we're going to talk about basilar skull fractures here in a second. And that big opening right there that we're looking at, that's your foramen magnum, and we talked about that in earlier videos. And where that foramen magnum is going to become important is towards the later part of this video when we start talking about herniation. And we start talking about brain tissue herniating down through the foramen magnum. That's the area we're going to be discussing. We're going to be discussing brain tissue pushing past the brain stem and into and through that foramen magnum. And that's where your brain stem comes down out of your brain, down into your spinal cord. That jagged, nasty, rough area you see there. So if we're looking at the foramen magnum and we come up, so to speak, up towards those four smaller holes, you see that rigid, rough kind of area. It's called a cribriform plate. That cribriform plate, and the best way I like to describe that, try to imagine, again, food, booze, sleep, and sex, what makes my world go round. Try to imagine a piece of cooked cauliflower. Now, you know how cooked cauliflower tends to soften up. So try to imagine that cauliflower sitting on top of a jagged cheese grater, or something to that effect, and now push that piece of cauliflower over the top of that cheese grater and pull it back again. If we have these big head injuries, which we'll discuss here in a second, of this coup-contra-coup motions, brain moving back and forth, the brain is literally sliding across this jagged skull floor, or basilar skull, which just destroys the bottom of the brain, creates hemorrhages, and a lot of problems. So by design, whoever put us together kind of goofed on that one. You know, why they put this delicate piece of tissue, being our brain, on top of this jagged platform. I have no idea what they were thinking, but that's what they did. So in this picture here, on this slide here, this is just giving you a little bit of a picture of one type of a basilar skull fracture. So like I said before, a linear skull fracture, just a straight line, we may never even know it's there. A depressed skull fracture, yeah, you may have a divot in someone's head or a dimple in someone's head. Little tip for you, don't push on it, right? If you push on that and their leg twitches and they piss themselves, well, you've probably done a little bit of harm. So you want to stay away from the smushy spot in their head. Open vault fractures, someone's head is cracked open like an egg, and I've seen quite a few of those. Those tend not to go so well for the patient. But your basilar skull fractures, they require quite a pop. They really do. Require quite a jolt. So let me go ahead and pull this slide down. So if we have somebody with a basilar skull fracture, the textbook is going to tell you you're going to see battle signs and you're going to see raccoon eyes. Yeah, okay, you very well might, but not for a while. In the pre-hospital setting, we're not going to see vital signs as a discoloration here behind the ear or bilaterally on both sides. Raccoon eyes, it looks like somebody got two black eyes, is what it looks like. You're not going to see that discoloration sometimes for days after the fracture occurs. So it's not the sort of an assessment tool we're looking for in the pre-hospital environment where we're trying to assess somebody for a basilar skull fracture. And, oh, I don't see raccoon eyes or battle signs, so it doesn't mean a thing, quite frankly. We're going to assess them differently, and we'll get into that here later. So when it comes to the fractures, there's really little for us to do other than recognize the fact that they could be there based on the mechanism of injury and treat your patient accordingly based on their signs and symptoms and how they present. Unconsciousness, airway control, just go ahead and assume. Go ahead and consider it's going to happen. They're going to puke. So be prepared for that airway management. That's going to be key. With head injury, we also talk about maxillofacial trauma. So in the prior slides that I showed you, we didn't get too much into facial anatomy, but your facial bones, there's a lot of different bones that make up your facial anatomy. So when we talk about maxillofacial trauma, we're talking about trauma to the face, blunt force trauma, penetrating trauma, something like that. There was a study done years ago by Dr. Lafort, and he looked at different fracture patterns from blunt force trauma to the face. So in this slide here, we're looking at what are known as Lafort's fractures or Lafort's classifications. Lafort's 1, 2, and 3. These are different types of fracture patterns to the face during blunt force trauma. Your Lafort's 1 is the lesser of the three evils, I guess. I wouldn't want any of them, but I guess out of the three, this one isn't so bad. But Lafort's 3 is basically, so Lafort's 1 comes right across your upper lip, essentially, and fractures that bone all the way to Lafort's 2 to Lafort's 3, where your face actually separates from your skull. And in prior videos, I discussed this and talked about donkey face. Their face will actually look like it's sliding down off of their skull, because it almost literally is. These are your patients that are similar to your basilar skull fractures, to where you may have CSF, cerebral spinal fluid, leaking out of their nose, leaking out of their ears. But it's not the kind of thing that I'm really going to spend a lot of time looking for. So I'm not going to, there's all kinds of nonsense that you can do. You can do what's called a halo test, and I'll pull this slide down. So if you have a basilar skull fracture or massive maxillofacial trauma, if you wanted to know, which really doesn't matter to us, if you wanted to know that they had CSF leaking out of their nose or their ears, technically speaking, and I've never done this, I've read about it, never done it in practice, but they say you can do what's called a halo test, and you can take a 4x4 gauze and you can dip it into the blood that's coming out of the nose or the ears, and the glucose of the cerebral spinal fluid will separate from the blood and create a yellowish halo around the drop of blood. That's called a halo test. Okay, good for you. You found cerebral spinal fluid coming out of their nose and ears. What are you going to do? Right? If they're suffering that significant of head trauma, you're going to see other things that are going to drive you in a direction to get them to a trauma center and so on and so forth. So, yeah, that's a nice test to do, but it really doesn't apply to us. So let's see. Let's talk about, and let's continue on, and in this same line of thought, we'll talk about traumatic brain injuries. Now, that's a hot topic, especially with our men and women overseas and blast injuries and TBI. It became a hot topic years ago, and it's a sort of a coverall term to say TBI, traumatic brain injury. That can be anything from a concussive blast to blunt force trauma to all the way to a subcategory of that DAI that we talked about, diffuse axonal injury. So let me just throw this picture up here. And what we're looking at with traumatic brain injury is your different causes. Again, concussion, contusion, coup contra coup, DAI, we'll look at blast injuries. But the one or the two categories of brain injury that we need to look at are your primary, secondary brain injuries. And that's sort of how head injuries are broken down, as primary, secondary injuries. Your primary injury is the insult itself, the blow to the head, the penetrating trauma to the head, the blast injury that affected the head. That's something that we have absolutely no control over. That was done before we got there. That was the mechanism of injury. What we're most concerned about are the secondary injuries, or the secondary brain injury, the now subsequent swelling of tissue because of that traumatic injury, the anoxia that can occur afterwards, the brain swelling. These are all things that we have a little bit of control over. Truly not a lot, but a little bit. So if we understand that there are two phases to head injury, well, if it's predictable, it's preventable, or at least it's anticipated, we know that if they've suffered a blow to the head, chances are they're going to start sustaining secondary brain injury, and we have to start treating to mitigate that, to slow it down, to lessen the dramatic effects of it, if you will. So let me go ahead and put this slide up. And this is just giving you a little bit of a better breakdown of traumatic brain injuries and how they occur, their subtypes, so to speak. So if we look to the right of the center, right, traumatic brain injuries in the center, and we look to the right, we see hematoma all the way to the right. So we have some sort of blood occupying the space. Epidural bleeds, subdural bleeds, subarachnoid bleeds, interventricular, intercerebral, interparenchymal bleeds. Intercerebral and interparenchymal. Interparenchymal is just tissue. So when we talk about the parenchyma of the lung, parenchyma of the brain is just the tissue. So that's bleeding inside brain tissue. Interventricular is bleeding inside the ventricles of the brain. And we'll get into epidural, subdural, and subarachnoid here in a little bit. You can have focal injuries, contusions, penetrating trauma. And as you slide your way to the left, well, now we have more diffuse injuries, concussions, DAI, blast injuries, shaken baby syndrome. I've seen a few of those. Those are never fun. Those are just depressing from the word go when we talk about shaken baby syndromes. But even shaken baby syndrome in the pre-hospital environment, there's no way for us to know, number one, that has occurred. That's typically something that's going to be diagnosed in hospital through a number of different tests. They'll be able to determine that. And we'll get into different types of head trauma here later that will and could mimic shaken baby syndrome. But again, pre-hospitally, there's very little we're going to be able to do to identify a shaken baby. Quite frankly, I don't know if I would even want to identify it in the field, because then you want to grab a hold of the parents that did it and you want to shake the shit out of them. But that's a whole other story in and of itself. So let's go ahead and talk briefly about concussion. All right?
Are you okay? Back off. He may have a concussion. A concussion?
You do me an honor, Lieutenant, but my dance card is full.
Hey, Stewie. How's our little concussion guy? Oh, my God. Can you see me?
Yeah, no, I'm fine. Is anybody gonna answer that telephone?
He keeps thinking the phone is ringing, Brian.
Well, at least he's talking again. I think that means he's getting better.
Is it day or night? I don't care. I just want to know. Lewis, answer the bloody phone!
No.
Poor Stewie. He's always having issues. I love Stewie. But the thing about that video that I want to point out to you, in that video, it shows Stewie being confused with a concussion. That's very true. What you'll find with concussion, depending on your grade and your level of concussion, will dictate how your patient presents, and we'll get more into that later. But they could just be a little dazed, a little confused. They could be unconscious. It just depends on their level or grade of concussion. But the one thing I wanted to bring to your attention in that video is the pupils. Right? One pupil is blown, and the other one is really, really small. Not to say that can't happen. What I'm saying is, we'll talk about herniation in a little bit here in this video. But if you have such significant brain injury that you're compressing that cranial nerve to create that blown pupil, they're not going to be conscious. They're going to be completely gorked. So someone who's looking at you saying, shit, I think my head hurts. You know, you have one blown pupil and one, they may have a glass eye. They may have just come from the eye doctor and had their eye dilated. Maybe a pre-existing condition. They probably do not have the kind of internal bleeding that's going to create that pupillary effect. Consciousness is huge. Level of consciousness is what drives your assessment for head injury. If your patient is lucid, talking to you, and fine, chances are everything up here is just fine. Will it stay that way? Who knows? All right, we have to wait and see. Could they be bleeding into their brain and it doesn't affect them for a week? Yep. In certain subdural hematomas, yeah, we can see that. So let me move on to this. This picture here is just a little bit of a picture of coup contra coup, all right? The primary, secondary impacts. Again, not primary, secondary injury that we just discussed, but the impacts. So when we are in a car accident, our head flies forward and it hits that steering wheel. All right, well, now the brain slides to the front of the skull and we have bruising to the front of the brain. Well, now as our head whips back and hits the headrest, well, now the brain comes back and hits the back of the skull. That's coup contra coup, forward and backward motion of that brain. So now you have bruising, cerebral contusion on the front of the brain, the back of the brain, and that brain has slid across that cribriform plate. So now you can also have some micro tears and some bleeding in the basilar area of your brain. So you got a lot of different things going on here. How do we know? Consciousness. When it comes down to assessment, what is their level of consciousness? What you're going to hear a lot of times when you come on scene, status post head injury, are bystanders telling you, oh, they were unconscious, they were unconscious. Well, now you get to them, and they're fully aware, they're alert, they know what's going on, they're totally conscious. That's very, very common. Okay, what happens is they got their bell rung, and now they're awake. Could they have a concussion? Yep, they certainly could. Again, depending on the grade. Could they have just rattled their reticular activating system? And we talked about that in prior videos, but just as a reminder, your reticular activating system, and let me go ahead and pull this slide down. Your reticular activating system is a network of nerve endings and sensors, if you will, all throughout your brain. And they sense motion, they're very attuned and aware of what you're doing. So if you have a rapid jarring of the brain, the reticular activating system senses this, and think of it like rebooting your computer. That's what your RAS, your reticular activating system, does. It will shut you down and reset you back to normal. So when you see MMA or boxing, pardon me, okay. Scotch, no, this is just juice. Actually, I got a dear friend of mine in New York. I drink Jack, he drinks Scotch, and I always wanted to find a ringtone. Scotchy, Scotch, Scotch. I love Scotch. And I wanted to make that as a ringtone, but I could never find it. One of these days I'll find it. Anyway, what the heck was I just talking about? Wow, totally. Thank you. When I do it on my wife, the reticular activating system. When you see boxers, MMA, whatever, when they get popped in the jaw, and then you see the slow motion, the jaw comes way over here and slides back, and the big line of spit goes flying. All right, really disgusting. What happens is the brain kind of gets rattled, and the reticular activating system says, nope, don't like it, and it shuts them down. And that's when they collapse, and they kind of lock up for a second, and then they relax, then they wake back up. That's what happens in a car accident. Same idea. They get their bell rung. They pass out. They fall back in the chair like this, or they slump over the steering wheel. Bystanders come over. Oh my God, he's unconscious. Everybody panics. Well, then they wake up. We show up. Bystanders are freaking out because your patient lost consciousness. Yeah, I believe they did. But now they're lucid, and they're conscious, and they're aware, and they know what's going on. That's normal. Now, depending on the severity of the blow to the head will dictate their prognosis. So let me go ahead and put this slide up here for a second. This is just showing a couple more examples, all right? Direct impact, that coup contra coup motion, blast injury. So part of your different categories of brain injury and the level of consciousness, there's a sliding scale. They say that your average concussion, quote unquote, classic concussion, you'll have a loss of consciousness less than an hour. Severe concussion is 1 to 6 hours. A mild diffuse axonal injury, you can be unconscious for 6 to 24 hours. And moderate to severe could be anywhere over 24 hours. But it's so hard to tell pre-hospitally what's going on in their brain. Here is my 2 cents. So if you have direct impact, coup contra coup, blast injury, whatever the cause of this brain injury is, let me pull this down. From a pre-hospital perspective, again, we're not trying to be surgeons, we're not here to be trauma docs, we're not here to be neuroscientists or neurosurgeons. We have to deal with what's right in front of us, based on mechanism and based on their presentation. If somebody takes a blow to the head, and they've fallen unconscious before we get there, or even while we're there, now they wake up, they may ask repetitive questions. Hey, what happened? You were in a car accident, you're going to be fine, blah, blah, blah. Okay. Hey, what happened? You were in a car accident. You'll get that question over and over again from a patient. That's normal. They've been concussed. They've taken a blow to the head. Do you know if they have a subdural bleed? No. Do you know if they have, a DAI or TBI? Nope. Again, here's my 2 cents. If the repetitive questions come or they pass out and they wake back up and their mental status continues to get better, they've got a good prognosis. If they pass out, wake back up, and they're awake and they're alert, but now their mental status starts to decrease, and they have a drop in GCS score by 2 or more points, and we'll go over GCS here in a little bit. It's a poor prognosis. That's the general rule. How do we know if it's a bleed, if it's DAI, and by definition, DAI is also considered to be what's called a shearing injury. And we talked in neurology, I think we talked about where your gray matter and your white matter come together. You have these axonal connections, and they communicate with each other. And at a very microscopic level, you have these little fine microscopic wires that connect. In a shearing injury or DAI, your white and your gray matter at a microscopic level shift and pull away from each other and break these microscopic connections. And that's what can cause your unconsciousness. So on a CAT scan or an MRI or whatever, there's no bleeds, there's no significant trauma to show up on a scan, but at a microscopic level, they're still rendered unconscious by these DAIs. And typically it's your more severe DAIs where this occurs. Pre-hospitally, there's no way for us to know. Your patient could be completely lucid with it and no issues whatsoever. but then all of a sudden, 3 days later, they slip into a coma. And you'll see that in some situations where you'll go to the unconscious, unresponsive. It's a young person, old person, man, woman, doesn't matter. Unconscious, they won't wake up. Family can't wake them up. They don't know what's going on. And part of your assessment, you'll start to see maybe that they have a head injury that we'll talk about here in a minute. Part of your line of questioning has to be, okay, have they been suffering from headaches lately? Did they sustain trauma in the last few days? Are they on blood thinners? Do they have hypertension? You go through your standard questions. And sometimes what you'll find out is, oh, they were in a car accident about 4 days ago. They hit their head, they were seen in the hospital, and now they're fine. Or they slipped on some ice and they hit their head. And they didn't go to the hospital, but they've had these headaches over the last few days. That's typical of a subdural bleed, a slow venous kind of bleed, and that's pushing their brain over time. And again, nothing for us to do about it, but we'll get into treatment here in a little bit. All right, let me make sure I'm staying on track. We talked about that, we talked about that. Let's talk about bleeding into the brain, shall we? Change my notes here to make sure I'm good to go. All right. Someone's bleeding into the brain, whether it be a medical reason, a trauma reason, doesn't matter to us. How do we know they're bleeding into their brain? A lot of times we don't. Whether it's a subdural bleed, remember we talked about the dura mater, and anything below is your subdural or your subarachnoid or your intracerebral, but anything above the dura, between your skull and your dura mater, is your epidural bleeds. And those are typically arterial in nature and faster. Your temporal lobes, here and here on either side, these are your thinnest areas of your skull are right over here. So any blow to the side of the head tends to be a bit more problematic because that's the thinner area. And in this area here, you have what's called your middle meningeal artery, and it actually runs in a groove. Right? So on the inside of your skull, there's a little valley, a little groove where this artery resides, and it kind of tucks itself in. It's pretty cool. But if we fracture our temporal lobe, there's a good chance that we're going to lacerate that artery. Arteries bleed like stink. That's what they do. And what will end up happening is that quick, hard arterial bleed will push that brain tissue over and create a lot of problems, but very quickly. So let me show you this picture here. And this is just giving you a little picture diagram of a subdural bleed, intracerebral hematoma, epidural bleed. It's your epidural bleeds that tend to affect your patient the fastest. These are the patients on scene. They took a blow to the side of the head. They fell unconscious. They woke back up, but then their level of consciousness slowly but surely deteriorated. These are your epidural bleeds. These are deadly. These will kill your patients quickly. Your subdural bleeds, these are the ones that are going to sneak up on your patient over a matter of hours to days and kill them slowly, if not addressed. Where your intracerebral hematomas, think of those more as your hemorrhagic strokes. That's the easier way to think about those. How do we truly know? We don't. We really don't. We're guessing. It's a swag. It's a scientific wild-ass guess. We're going to look and say, I don't know, we think maybe they have, a bleed, and we're kind of guessing, but we have to go based on signs and symptoms. So when we talk about signs and symptoms of head injury and bleeds, whether it's an epidural bleed, a subdural bleed, intracerebral bleed, doesn't matter. Remember, level of consciousness is what's really going to dictate it's going to dictate the severity of their injury is going to be their level of consciousness, which is the best way of saying it. So let me pull this down. So when we do our assessment of a head injury patient, level of consciousness. Now, in prior videos, I talked about the eyes being the windows to the brain. Yes, from me to you. If your patient is lucid and talking to you, I am never going to say that looking at someone's pupils is a bad idea and a waste of time. No, I'm not going to say that. However, if they're lucid, talking to you, cognitive, answering all your questions, what is the point of the pupillary check? All right? Everything's working. So what are these going to tell you? Only time your patient's pupils really come into play is if you have altered mental status. Because now you can, all right, are they sluggish? Are they pinpoint? Are they dilated? Is one larger than the other? Now you're going into neurological assessments to figure out what's going on in their brain. So everything from altered mental status all the way down to paralysis could be head injury.
All right, you two, up and at 'em!
I can't feel nothing in my leg!
A little bit of a blast from the past there. Stir Crazy, for those of you who remember that movie. I love Gene Wilder and Richard Pryor. Those two together were a magical couple, those two. They were so funny. Anyway, so if we let a bleed run amok, and usually where we're going to see this again is in your more acute settings, is in your blow to the side of the head, your epidural bleeds, there is a difference between intracranial pressure and somebody who's herniating. And this is where a lot of providers end up getting confused because your treatment can be tweaked a little bit one to the other. So let's just talk about somebody who has a bleed into their brain and they're showing signs and symptoms to suggest that versus somebody who's having what's called herniation. So first things first, someone's bleeding into their brain. They're going to have mechanism of injury, could be a blast, right? Could be penetrating trauma, could be blunt force trauma. Could be any one of them. Quite frankly, it could even be a hemorrhagic stroke. But let's just go on the trauma side of the house. They're bleeding into their brain. If they are conscious and talking to you, don't worry about it, right? Because there's nothing going on up there yet. Could it progress to that? Yes, absolutely it could. That's why you constantly have to reassess and watch your patient. Once they start slipping into unconsciousness and they get lethargic and goofy, you get the nods on you, okay, now there's something going on up here, and you got to really watch them closely. If they start to show signs and symptoms over time, or what's called Cushing's triad, let me show you this picture here. Cushing's triad or Cushing's reflex is the body's way of forcing blood up into the cranial cavity. So if you think of it this way, cerebral perfusion pressure. When we talk about cerebral perfusion pressure, by definition, cerebral perfusion pressure is mean arterial pressure minus your intracranial pressure. How are you going to know either one of those? You're probably not. There are ways to figure out your mean arterial pressure. Don't worry about it. There is no way for us to know their intracranial pressure unless we put a ventricular shunt in their head and measure it. We're not going to do that. So I don't spend a whole lot of time on cerebral perfusion pressure. But to lead into that, your brain is very, very susceptible to hypoperfusion. So with TBI, the main treatment and the main thing that we're thinking about with TBI is what we call 90, 90, and 9 as far as an assessment tool. At any given time, if we let the patient's SpO2 drop below 90%, if we let their systolic blood pressure drop below 90%, or if we let their overall GCS score drop below 9, we have just doubled their mortality. So our goal in traumatic brain injury care and head injury care is keeping their SpO2 above 90, keeping their systolic blood pressure above 90, and trying to maintain a GCS total score of above 9. That's our ultimate goal. So keeping them oxygenated, maintaining their airway, maintaining their blood pressure. Well, blood pressure goes hand in hand with your cerebral perfusion pressure. So let's think about just basic physics and basic hydraulics. If we have bleeding into the brain, bleeding into the cranial cavity, well, that's forcing an increased pressure down through the foramen magnum, which is the majority of where your blood is coming up into your brain. So if your body senses that it's meeting resistance in getting blood up into your cranial cavity, well, what's it going to do? It's going to increase blood pressure to force blood up into your cranial cavity. which is somewhat self-defeating because now you're probably making your bleed worse. But so one of the things you're going to have with Cushing's reflex or Cushing's triad is you're going to have what's called a widening pulse pressure. By a widening pulse pressure means your systolic BP is going up and your diastolic BP is going down. That's your widening pulse pressure. You'll also have a decrease in heart rate. That's because of the compression on the brain stem. And you're also going to have it says here, a diminished respiratory effort or bradypnea. What you're actually going to have are these irregular, erratic respiratory patterns, Cheyne-Stokes, Biot's, ataxic type of ventilatory patterns. Are very bizarre. That's because of the pressure being put on the brainstem at that foramen magnum. And that's what's causing these signs and symptoms. So this is just increased intracranial pressure giving you Cushing's triad. Well, now let me change the slide. If we start to get to the point where the pressure in the cranial vault is getting so great that the brain tissue has nowhere else to go but down through the path of least resistance, which is your foramen magnum, well, now you're going to start herniating. So if you look at this picture on the bottom, you'll see what looks like discoloration or tissue being pushed down through that foramen magnum. That is herniation. That is bad, right? So the best way to think about it is if you believe your patient is herniating, okay, they're going to have Cushing's triad plus posturing. And what posturing is on a GCS score, if we're looking at eyes, verbal, motor, right? Motor is a scale of 1 through 6, 6 being the best, 1 being absolutely no muscular tone whatsoever. A 2 and a 3 in your motor score, and we'll see this in the next slide, that's posturing. Now you can have decorticate or abnormal flexion or decerebrate, abnormal extension. That's posturing. So if you think your patient is herniating, that's what you're looking for. You're looking for Cushing's triad plus posturing. That's herniation. Prognosis, bad. Right? Let me pull the slide down. So if we've gotten to the point where we believe our patient is herniating, there's very little we can do. There are some things we can do, and we'll discuss that. So as far as an assessment tool goes, your patient's unconscious, unresponsive. If they're herniating, they're not looking at you. They're not holding a conversation. They're not going, my head hurts. This patient is gorked. They will have Cushing's triad, so they'll have an increased blood pressure or a widening pulse pressure. They'll start to develop bradycardia, and they'll start to have irregular respiratory patterns. Now you think they're herniating, they're going to start posturing, either decorticate or decerebrate, and they're in a big bad way. They may start to convulse a little bit and seize. The only thing you can really do for these patients is manage their airway and go like hell. They have to get to a trauma center. That's the only thing that's going to help these patients. Now, on the advanced side of the house, if we were to intubate these patients, and the general rule of thumb is GCS less than 8, intubate. And I don't necessarily subscribe to that. So if that were the case, I would probably have about 10,000 intubations under my belt. So every drunk you run across is less than 8 on the GCS score, and I'd be intubating them. So it's got to be in the presence of significant head injury to really follow that rule. But if we do intubate them, normal ventilatory rate, if we're bagging a patient who's intubated or not intubated, anywhere from 10 to 12. We don't want to go crazy. Hyperventilation in an adult is 20. And I see people routinely bagging patients at 20, and that's not good. But if we were going to treat somebody with herniation, we would want to hyperventilate them, the adult, at a rate of 20. And we want to keep their end-tidal CO2, normal end-tidal CO2, if we have them intubated, is 35 to 45 millimeters mercury. If they're herniating and we're trying to reduce the amount of bleeding into the brain or slow it down more significant or more specifically, we want to keep their end-tidal CO2 at about 30. What that does, it blows off more CO2. By hyperventilating at 20 and keeping their end-tidal CO2 at about 30, which is a little lower, we promote cerebral vasoconstriction, and we're slowing down the bleeding in the brain. We're not fixing them. We're slowing down the bleeding in an attempt to buy them time to get them to a trauma center. That's the only indication or only time we would ever consider hyperventilating a patient at 20 is in the presence of herniation. If they just have head injury, if they're just showing Cushing's triad, it's really not an indicator for us to start hyperventilating them. Only if they're herniating should we consider hyperventilation. That's pretty much it. So let me show you this slide. And this is your Glasgow Coma Scale. Glasgow Coma Scale was actually created by a doctor in Glasgow, Scotland, at a neurological center. And it's designed specifically for neurological assessment of the head injury patient. We have bastardized this and mutated it over the years in EMS to fit anything. Drunk, the little, the person laying in bed that's altered mental status. That's not an accurate assessment of your patient who's just altered mental status. This is really only designed for the head injury patient. It looks at eyes, verbal, and motor. 4, 5, and 6. 15 is the absolute best you can have. 3, collectively, 3 from all 3 areas, is the absolute lowest you can have. So somebody who's been dead for 10,000 years gets a 3. We, being awake and alert, hopefully, listening to this, we get a 15. We can never go any lower than a 3 total, but we can go a 1 in eyes, a 1 in verbal, a 1 in motor, if that makes sense. So if you look at that scale, if you roll into a trauma room and you're given a report, they want to know, and it's a significant trauma patient with head injury, they want to know what the patient's GCS was when you got there, what their GCS was while you were transporting, and what their GCS is now. That is going to tell them volumes. Because if you have a patient whose GCS has deteriorated by 2 or more points over a certain period of time, status post-injury, that's a very poor prognosis. Whereas on the flip side of that coin, if you have a patient whose GCS score increases and gets better by 2 or more points since that point of injury, that's a very positive prognosis. If you walk into a trauma room and they say, well, what was their GCS on scene? And you say, I think it was about an 11. They have completely disregarded what you said. Because if the words I think come out of your mouth and you just spit a number out, they're not going to believe you. They're not going to listen to you. You need to say to them, upon arrival, patient presented with a GCS of 10. Their eyes were this, their verbal was this, their motor was this. In transport, 10 minutes later, approximately 15 minutes ago, their repeat GCS was at 11. Their eyes were this, their verbal was this, their motor was this. Now, as we've pulled into the ER, here is their GCS. It is now a 13. Their eyes are this. That you have to spell it out for them. If you put that out to a trauma room during a report, they're really going to listen to you. If you say, I think, or it was about an 11, or if you just spit out a number and don't back it up with those specifics, they're not going to listen to you. They're going to disregard it. So my advice to you is don't lie. If they ask you what was their GCS, tell them, you know what, I really didn't get one. When we got there, he was completely out. He started to become a bit more responsive en route, and now he's fighting us. Okay, that's a good assessment. It's not giving them the GCS that they want, but it's something. If you start rambling off numbers, you've blown your credibility. Let me go ahead and pull this down. The GCS score really is pretty difficult to remember. I've had it remembered or memorized for years. Number one, because I'm a nerd and I have nothing else to spend my time doing. Number two, I used to run a lot of head injury patients, especially on a flight team. So you had to kind of have it memorized. But cheat sheets for my FBI personnel, I've made field cards. These little cheat sheets are available on the SharePoint site. Go ahead and download them. GCS is on there. I have absolutely no issue with a provider who's staring at a cheat sheet and figuring out a GCS. Of course, as long as their airway has been taken care of, the patient's stabilized, all the serious shit is done first. Now, if you really want to sit and try and figure out a GCS, more power to you. Is that going to save their life? Should that take any priority in your treatment modality? No. Right? Take care of the airway, all the important things first, the bleeding. So let's see. I think we've covered just about everything that I wanted to cover in head injury. This is the tip of the iceberg again, but as a general rule, I like to go over the differences between concussion and intracranial pressure, differences between intracranial pressure and herniation, and how they may present a little differently from the acute onset to the late onset of hours to days later. Just don't turn your back on a head injury patient. They can go from stable and talking to you to unconscious, unresponsive in a matter of minutes. You just never know. Should you be super paranoid and you're on a mission or you're on a training exercise and somebody whacks their head and they got their bell rung? Do you rush them to a trauma center? It's a judgment call. You got to look at the mechanism. You got to look at what protective gear they had on, take in all the variables. But if you have an operator or you have somebody who you work with that just whacked their head and they refuse to go to the hospital, or you don't think it's necessary, just watch that person. Watch them closely, just to be on the safe side. Okay, I think that's it for head injury. Code word, let's see. Code word. Huh? No, we just did bird the other day. Hummingbird is too long. We have a hummingbird outside the window. It's a hummingbird. Huh? Cat? Okay, cat. How about that? I'm not a cat fan. I don't like cats. My wife loves cats. I hate cats. But cat, meow, cat. How about that? That's our code word for this video is cat. I'm glad to be back. I missed everybody. I'm happy to be back in the saddle, making these videos. Again, like I said, we'll probably scale them back to one a week, and I'll try to release them on Tuesdays or Wednesdays, depending on what's going on. I had a great time. Thank you very much. I hope everybody's doing well. Stay safe, and we'll see you on the next one. Take care.